welcome back to the channel, starring your co-host, Teddy. Teddy the co-host. You good boy. Hey, the camera's over here, Ted. Look, follow my finger. Oh, look at the camera. Good boy. Have an extreme close-up. Oh my god, so close. Look at that definition. Okay, he's a bit camera shy, but he'll be hosting with me today. Let's get started. Hey guys, welcome back to the channel. My name's Aaron and I'm a third year medical student from University of Adelaide, and that's in South Australia. So first up, I've got to say sorry for the lack of videos lately. I originally planned to upload videos like one video every 2 weeks, but a month ago I actually broke my collarbone in footy, so I wasn't really feeling up to it. But the good news is I'm on the recovery and I'm back. So the purpose of this video is to talk about what I do on clinical days in the medical school. So clinical days occur one day per week, and the whole purpose of those days is to prepare you for the actual clinical rotations that you do in years 4, 5 and 6. So clinical days for us, for year 3 students, normally consists of the following things. So in the morning you've got a masterclass which covers a range of topics. You have some tutorials throughout the day, such as how to use an ophthalmoscope, wheelchair stuff, and vascular workshops for people with diabetic foot disease and ulcers. You also get to roam around the hospital on the ward that you're allocated to and practice your histories and examination skills. So my idea is to make a sort of a video blog, or I think it's called a vlog actually. Yeah, to make a vlog on my clinical days and just talk about what I cover. Talk about what I cover on those days and talk about any interesting diseases that I come across. So, in the morning, for an 8 o'clock start, we do our masterclass. The masterclass runs for around 1 hour, and specifically for my most recent masterclass, it was a session on renal examination and history, and that was run by a nephrologist. Just to summarise what we just covered the common presenting complaints for kidney and UTI diseases, and these complaints include like dysuria, which is pain on urination, and also hematuria, which is blood in the urine. And we also covered the full renal examination and what findings you should expect to see for someone who has kidney failure or other sorts of renal diseases. So I arrive at the hospital and I immediately get lost because this is like my first day. I missed the orientation because of the shoulder, but I was pretty lucky though, because I just like seamlessly joined the group of students and found my way to the staff room. So just the structure of how things are sorted out. Every student is allocated to a home ward. So that's the ward that you stay at or start at just for the term. So for me, I am in the spinal ward. Every student is paired up with someone else just so they can be safe when they interview patients. But that being said, even though I'm on the spinal ward, I have made my way down to the cardiology ward as well, just because those patients are really good to take histories from, and they have lots of findings on the examination. So once we get to the ward, the spinal ward, we basically have until 9 o'clock in the morning to 4 o'clock at night to do whatever we want basically. So we can join in on a ward round, we could take histories and do an exam on the patient. We can practice using the computer system to access patient records. Basically, yeah, to just get as much exposure to different things as possible. So once we got to the spinal ward, we talked to the nurse unit manager and we introduced ourselves as medical students, and we just asked her what patients would be suitable to take a history from and do an exam on. And she pointed at something in the distance. I looked around and there's a big whiteboard with around 20 names of patients on the whiteboard. So each patient had their own room allocation, and it had like their details, how long they'd been in the hospital, as well as their name and age as well. And the nurse went through all the people on the list. I don't really know how she actually remembered every single detail, but it was pretty good. So we had about 5 people picked out who we could see that day. The first person that we saw, actually, I'll tell you the story now. Just to let you know, every patient I talk about has been de-identified, just to maintain, you know, their confidentiality and stuff. So the patient we ended up seeing on the spinal ward was a woman in her 30s. And the reason why she was there is because she herniated her disc, like a disc in her back. With this herniated disc, it caused pain immediately once she did it. And the pain was in the lower back and shot down this side of her right leg. So those symptoms suggest that the herniated disc is now impinging on a nerve, one of the spinal nerves. The problem is that we don't have any idea which spinal nerve the disc is impinging on, which is why we do the physical examination. And the examination that we did in this case is the lower limb neurological exam. So I hadn't actually done this exam in a while, so I kind of forgot a few steps for it. But it actually turned out fine because the patient wasn't really able to move without pain, so we didn't have to do any of the motor function, or we didn't have to move her around that much. But one thing that I did do, which was pretty useful, was to test the different types of sensation in the lower limb. I'll get the equipment and I'll be back. I'll show you what the equipment looks like. Alright, I'm back. So the first piece of equipment, it's really high tech. It's used to determine whether the patient has fine touch sensation. And the equipment is just cotton wool balls. So this is the bag it comes in. We just got it from the container on the floor. And what you do is that, so you've got the cotton wool ball, and you just make it really fluffy on the end, and you touch each of the patient, you touch different parts of the patient's leg while their eyes are closed, and they just tell you whether they feel the sensation and if it feels the same between each leg. Yeah, so actually with the fine touch for this patient, she couldn't feel it on the side of her leg, so the lower leg on the lateral side, so the outside, and I'll tell you the significance of that in a minute. But the other modalities we tested as well. So the second one we tested was with, so it's for pain sensation. So this is like a neurological pin, and it's got a sharp point on the end, if we can see that. No, we can't see it. Oh well, you have to pretend there's a sharp point on the end. And there's a dull point on the other end. So we touched the same areas on her legs that we did with the cotton wool ball, and we touched it with the pin, and asked the patient if she could feel it. And again, there was a deficit on the side, the lateral side of her lower leg. And the other thing we did was this thing called proprioception. So it's when you get the big toe and you either move it, you get the patient to close their eyes, and you either move it up or you move it down, and the patient has to tell you what direction you move it. So that's called proprioception. And the final thing I tested was vibration. So basically, just pretend this thumb is the big toe. It's pretty similar. So you get the tuning fork, make it vibrate, and you stick it on top of the thumb or the person's toe. And with the eyes closed, they say if they can feel it or not. And then as the examiner, you stop the tuning fork and they have to tell you when the vibration stops. So for this patient, proprioception and vibration were both fine, but her fine touch and pain sensation was not intact. And since it wasn't intact on the outside part of her lower limb, that indicated that the disc was impinging on her L5 nerve root. So I'll put a picture up on the screen, and so this picture basically just looks at the different dermatomes. So certain nerve roots supply certain parts of the skin. So this took actually a long time. We were there for like an hour. I mean, ordinarily in a examination or assessment scenario, you get like 8 minutes for the history and 8 minutes for the exam. So we took way longer than what we should have taken. But the patient was really nice, and we got to actually see some signs in her, which was good. And after this, so yeah, we finished off with this patient and we left the room, but I actually had to go and do a clinical case presentation. So I missed it in the first couple of weeks, so I had to do it now. So I had to go away back to the university for an hour, do the thing, and then come back. So once I came back, I joined forces with my partner once again, And instead of going back to the spinal ward, we went up to the cardiology ward to check out the patients there. So just like before, we talked to the nursing unit manager on the cardiology ward. He directed us to a few patients who he thought were suitable for us to take histories from. And I'll talk about the most interesting patient now. So we saw 3 patients. This is the one patient who was pretty interesting. She was a woman in her 20s, and the reason why she was in hospital was due to a disease called infective endocarditis. And basically what that is when bacteria enter the bloodstream and make its way to the heart, and then it colonizes the valves within the heart. As a result, this causes heart failure because the heart valves are no longer functional and become like really floppy. And when the bacteria colonize the valves, they form a little clump of material known as a vegetation. And this material, or this vegetation, is pretty dangerous because not only does it stop the valves from functioning properly, but little bits can actually break off and go further upstream and block vessels upstream, which is what happened to the patient that we were talking to. So basically, yeah, she had a vegetation, the part broke off and it got lodged within her lungs. So we asked the patient how she felt when she first presented to the hospital. So what sort of symptoms was she having because of this infective endocarditis? And what she described is feeling really sick, and she had a high fever, and what else did she have? She had dyspnea, which is shortness of breath. How did this bacteria even get into the bloodstream in the first place? The answer in this specific case would probably be IV drug use. So intravenous drug use opens up a passageway from the outside world into the bloodstream. So after we saw this patient, it was now time to have our integrated case. This case is a Zoom session which the whole cohort joins, and it's directed by our coordinator. And basically every integrated case covers a different topic each week. This week we covered a topic known as septic shock, which is convenient because the woman we were just talking about had septic shock. And septic shock is basically when bacteria enter the bloodstream and cause massive inflammation, and leads to a massive drop in blood pressure. And as a result, the organs throughout the body are not well perfused with blood and can potentially die if the blood supply is not restored. So once that lesson was over, it was now 5 p.m. at night time. And at the end of each clinical day, what each student does is they add their experiences of the day to a portfolio and then write a small reflection on each case and write some ideas on how to improve. It's like one of the obvious things I can improve on is the fact that I forgot like 75% of the neurological exam. So improvement would be to revise that. That's the end of the video. So that was episode 1 of my hospital blog. I hope you guys found it interesting and it gives you some idea on what stuff you can encounter as a early year medical student, so years 1 to 3. If you have any questions, ideas, or any feedback for the video, feel free to hit me up in the comments section down below. And if you like this video, liking it would be nice, and subscribing to the channel would be even better. But other than that, thanks for watching, and I'll see you guys around for the next episode. Check if he has a pulse. Yeah. I don't really feel anything. His eyes are open, but there's no response. So obviously lesson 15 on the Glasgow Coma scale. Got treats? Want some treats? Well, he's alive. Here we go. It's like epinephrine or adrenaline. He's back to life. Hey Teddy, you okay, my friend? All good? Yeah, he's all good. Look, you're alive, buddy. Go back to sleep. Go back to sleep. Go back to sleep. I'm sorry. There's no treats for you. I'm all out of treats. Sorry. I should stop bullying you. You were sleeping. You're having a dream. And then Aaron came in and turned that dream into a nightmare. Want to say goodbye to everyone? Want to say goodbye? Goodbye, guys. I'll see you in the next video. Goodbye, everybody.